So what did we say the main issues were in the pre-operative period as far as our role with the patient? Relieve anxiety and safety and knowledge, education, right. Taking care of that knowledge deficit, great. So we've got our patient prepped, ready. We are now moving them to the operating room, and we start the intraop phase at this point, okay? Now again, our big things here are safety, patient advocacy. Remember, we're going to have a patient that's sedated or completely out of it, not able to tell us what's wrong, how they feel, it can't communicate. And then the third one is that the controlling of all those potential hazards that are in the operating room. Okay? This is kind of what an operating room looks like when it's just real nice and pretty and clean and neat and not anything's going on. That's not the way it stays. Your book has got some pretty intense pictures there of what an operating room. How many of you have been in an operating room like to see something? I don't mean you're snockered, but yeah. So you know how it's a pretty cluttered looking type of atmosphere there, but those people pretty much know where everything is. Things have to be set up in a certain way, especially when you're looking at the sterile field. The patient has to be put a certain way, and we'll talk about that. But it's a lot of equipment, a lot of people, a lot of sights and sounds going on in there. So you'll see that when you do your OR rotation. But you're going to see an awful lot of people that are working in the operative area, even in each operating room. Okay, and you need to kind of understand what everybody's role is. Okay, certainly the captain of the ship is the surgeon. This is the person who is responsible for the procedure itself and responsible for any kind of surgical judgments that need to be made. Okay? If they get in there and find out there's other issues going on than what was planned, those type of surgical issues about what do we need to do about this, those kind of things. The surgeon usually will have a surgical assistant. It may be a trained surgical assistant, physician's assistant, might be another physician. And really a surgical assistant, you're going to use those in the more complex cases, open cases. You don't do those, you don't have a lot of surgical assistants when you have the laparoscopic procedures. Then you have the folks that are responsible for the anesthesia. The anesthesiologist is the physician. And then the anesthetist, who is a certified registered nurse anesthetist, is working under their direction. A CRNA is an RN that has their BS degree, and then they usually require 2 years of working in a critical care area, and then they have to go to CRNA school. So it's a lot of extra training and certification to get there. Anybody interested in CRNA in here? Good. Yeah. It's a happening area. And a demand for those folks. So you should be able to find a job. But these folks here are the folks that are responsible for inducing and maintaining the patient's anesthesia throughout the procedure. They're also monitoring other functions. These are the folks that are monitoring the bodily functions of the patient, especially the cardiac and respiratory status. They're monitoring vital signs. They're monitoring IV fluids, intake, output, those kind of things. Okay. Then we get into the nursing area. Lots of different nursing staff back there. The first one that your patient comes in contact are the holding area nurses. These are the folks that kind of welcome them to the OR when they get there. Your patient usually goes to a holding area where they wait to be moved into the operating room. Okay, we'll talk about what their role and function is. Then you have the circulating nurse. Now, this is the primary nurse in the operating room. All right. This is the person who is responsible for all of the patient care that happens in the operating room. The physician's driving the boat, but she's pretty much steering it. Or he's pretty much steering it. Okay. This is the one that's responsible, like I said, for the patient care. She's, or he, sorry, y'all, I'm just used to she, so just go with me. But this nurse is the one that makes sure the room is ready before the patient is allowed in. Okay? This is the circulating nurse. She coordinates and oversees the patient care. She sets up the room. She makes sure that the bed is ready for the patient, that it's clean, got the linen on it, the straps are there, everything that we're going to need to position the patient is there. The circulator checks all the equipment, makes sure that the equipment is there and working. And then once the room is ready, then they allow the patient to be wheeled into the room, and then the circulator actually helps to get the patient put on the bed, positioned appropriately, padded, all that business. And then they also will be the person who's going to put in the Foley if a Foley needs to be put in at that time. And they also will be the one who scrubs the surgical site. Okay. So big job for the circulator, and that's just pre-op before they've even done the cut. Okay. Throughout the procedure, the circulator is responsible for kind of monitoring the room. Okay, making sure that all the supplies are there. This is the person who is keeping count of sponges and needles and sutures and all that stuff. This is the person who doesn't let anybody out of the room until those counts are correct. Okay. The circulator is the one who documents the room and the patient care in the room. Now, anesthesia is doing their own documentation. Okay, they usually will have a flow sheet, but the circulator is documenting the patient care and everything else that's going on. Usually by flow sheet as well, but there are some narrative notes that the nurse can make. You also have scrub nurses or scrub techs in there. These are people who are actually scrubbed in and sterile. This is the person who hands the instruments, okay, and maybe helping to do some retraction, maybe helping with the surgery to some degree. Okay. This may be a nurse, or it may be a person who has special training and is certified as a scrub tech. This is the person who sets up the sterile table. The circulator takes care of the room, but the sterile field, the draping of the patient, all that business is done. The scrub tech is responsible for that. Scrub tech is usually the person who scrubs in first and then sets up the table, and they're standing there waiting for everybody else. Okay. Helps the surgeon get or the circulator helps get them sterile, dressed out and all that business, but then the scrub tech is standing there waiting. Okay. You also have other ancillary personnel in the OR. You may have x-ray techs coming in and out. You may have, it depends on what's going on, what type of surgery it is. Okay. But you usually will have this team in your room. They know what their roles are, and they're very specific. Not a lot of crossing over roles, because what happens then you open up the chance of making errors or something being forgotten. Okay, so usually their jobs are pretty straightforward, and like I said, the circulator doesn't usually scrub in the middle of a case in case they're needed. No, she's running the room. Okay. So when we're talking about the OR personnel, certain standards you got to have in order to work in the OR. Okay, and of course there's the National Association of OR Nurses that have a lot of standards. But and as when you're looking at patient safety, Joint Commission plays a role in it. Core measures. Remember we talked about SCIP. This is part of SCIP as well. Okay, the intraoperative period. So when you're talking about people working in the OR, these folks have got to be healthy, okay? They can't be just dragging in with a cold and a communicable disease and all that business, because there's such a risk of infection back there. So they got to have good personal hygiene. They've got to meet a certain requirement. They can't go back there with their false nails on, and they've been at the club all night and they're just dragging in and all that business. So they got to meet that standard. All right. Good personal hygiene. They can't be sick. They cannot be sick. They cannot have any kind of open wound. No colds, no infection. Now, when people work in that operating room, then they have to dress out in surgical attire. Now, their clothes are not sterile. All right, their clothes are not sterile. They're clean, but they're not sterile. That's why you see the operating room staff. They wear people clothes into work, and then when they get there, they change into scrubs. And usually, those scrubs are provided by the organization. Those of you who are doing, OB at Decatur, you'll wear your clothes in and then change into your scrubs there. They don't want you bringing in stuff on your clothes. Okay, that's the purpose of that. It's an infection control issue. Okay, so OR, you can wear your scrubs in there, but they'll have you change clothes. You wear your uniform, and then they'll have you change. Don't they have you change, or did they keep? Okay, it really just depends on the organization, because you're there in an observation thing. Did they put a gown on you? They did put a gown on you? Okay. Well, we wouldn't want everybody to be the same. Yeah. Up on the screen. Your experiences are going to be so different, because it depends on what the surgery is. It depends on who's in the room. Yeah, wear your uniform. Wear your uniform, and then if they want you to change, they'll give you the scrubs. But the folks that are working there, they don't wear their scrubs in. Not the scrubs that they're going to go into the OR in. All right. They'll change clothes. They have to put a covering over their hair. Even facial hair has to be covered. Okay. Anybody who goes into the OR must have a mask. And then they have shoe covers. Most of your places have a big red line, and anybody that goes over that line has got to put covers on their shoes. So infection control is a big, big issue, huh? They did make you do that, yeah. Okay. They're very, very strict. They're very, very strict. Yeah, very strict on that. And they have to be. They have to be. You know, they really do. Yeah, if that was you want sterile. Absolutely. Okay, so certain surgical attire they got to have. Okay, and then they've also got to do a surgical scrub. All right. Now, surgical scrub this is a 3 to 5 minute scrub from above the elbows on down, right? With an antimicrobial scrub, either Chloroprep, betadine, something like that, okay? And it does not make the skin sterile, but it removes the majority of the microorganisms on the surface of the skin. But what you have to be careful. What did you learn when you were doing hand washing in 102? When you get through, what do you do with your hands? You're holding your hands down and all like this. With the surgical scrub, you're holding your hands up. Okay? You don't want stuff running down on your hands. Okay? So once you're through, and the sinks are all controlled by your feet. Okay? So once you're scrubbed in and you've done all this business, then you step back from the sink and you hold your hands up above the level of your waist, and usually the person will back into the OR, hitting the door with their back. They don't touch anything, and then once they walk into the OR, the scrub tech is there with sterile towels to dry their hands, and then they will put on their gowns, their sterile gowns, their sterile gloves at that point. Okay? So then they're sterile. Their clothes are not, but they will put on a sterile gown. There's a picture in your book of what somebody looks like, dressed out like a spaceman. But the gown is fluid resistant. Okay. A lot of splashing and stuff, or potential for splashing. So once your person is scrubbed in, they have a sterile gown on, sterile gloves. They have a mask with a face shield or goggles, whichever. They'll have a hat on, and they will have shoe covers on. That's your standard attire back there. Okay. So once your patient gets back to the OR, your patient is like I said, put in the holding area. There's usually a nurse responsible for, greeting the patient, having a discussion with the patient. This is just the next step in making sure that we've got the right patient, that we are there to do the correct surgery, the right side, all that business. The holding nurse uses this time to review with the patient what they're having done, to review the chart. Okay. They're confirming that we've got the patient. How do we confirm in healthcare that we have the right patient? You ask them their name and check their armband. Can we always go by what they say their name is? No. So that may not be the be-all, end-all way, okay? But you always have to have, how many identifiers? 2. Always. 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 Okay. Always 2 identifiers, and please don't use the room number as an identifier. Okay. All right? So we're identifying the patient. We're confirming that we're there to do the procedure that the patient thinks. Okay, we ask the patient, what are you having done today? All right. Making sure all of the paperwork is completed. Do we have a consent? Okay. We'll also mark the site at this point if the surgeon is available to do that. Now, the site marking may be done once the patient gets in the OR room, the operating room itself, okay? Got to make sure the paperwork's all completed. Review the chart. This is the time for the holding nurse will use this time to look at a little bit of the history, making sure that risk factors, all that business, and they may be communicating that to other members of the operating team. Okay. Not everybody is going to be digging in the chart right before the surgery like the holding nurse is. Okay. We want to know allergies. We want to know that those pre-op labs have been completed and are on the chart. Hopefully the patient has not left the pre-op area without the pre-op nurse checking that, but it's just another fail-safe that we make sure everything's there. We also want to know, does our patient have an advance directive, and are they a do not resuscitate? A lot of your, yes ma'am. No, they'll do a timeout too. When they get in the OR, they will do a timeout. They will do one more timeout before they actually put that patient out. Yes, yes. But sometimes the physician, the surgeon is not available right then in the holding area to mark the site. So what they do is when they roll the patient into OR, before they do anything else, they will have the physician or the patient mark the site with everybody in attendance. It is a timeout. It is a timeout, yes. I'm not going to ask you how many times they do one.
Right. I just wanted to clarify that would be.
Anytime everybody just kind of stops and stands back and say, okay, we have got Ms. Osborne, date of birth is this. Ms. Osborne, what are you here for today? You know, which side is it on? It's right here. I need you to mark. Okay. Okay, you're welcome. Okay. So we want to know about advanced directives. We want to know about DNRs. A lot of your facilities do not honor a DNR. What is a DNR? Do not resuscitate. A lot of your facilities will not honor that while the patient is in surgery, because the patient is at a different level of care, and we're putting them almost in a resuscitative state. So if they get to where, you know, they just go on out, do we bring them back if they're a DNR? I mean, it's an ethical issue, you know, it really is. At my hospital, they don't, unless they've changed, they don't honor DNR. DNRs are put on hold while the patient is in surgery. If they have for sure, if they have a general anesthesia. But your book, I was noticing last night, is talking about how they're really looking at maybe that's not right, because the patient has said, I do not want to be resuscitated. So do we have the right to say, well, that doesn't count when you're in surgery? So, see, it's an ethical issue. But, you know, if that's my wishes, that's my wishes. You know, I can see both sides of the coin there. Yes, ma'am. It was null and void if he had the surgery. Yeah. So you just have to know, you know, and the team needs to know if it is, you know, what the patient's wishes are. All right. So we're also making sure that we know about their allergies. We're making sure that anesthesia has talked to the patient, okay, and interviewed the patient. And is the patient ready? Okay. Have they had their pre-op meds? Are they Are they in the appropriate gown they need to be in? Have they removed their finger? You know, all that stuff on that pre-op checklist? They're kind of reviewing that again. Have they been in PO? Have they got their nail polish off? Have they removed all their jewelry? Have they voided? Have they taken their drawers off if they need to? Those kind of things. So just making sure, because once that patient rolls into the OR, there's no stopping at that point. All right. So when the patient has been through holding, all the interviewing's been done. All right, we've done a verification that we've got everything ready. The patient rolls into the OR. Once the patient is in that room during the operation, three main problems that we're concerned with. Okay, there's a risk for injury based on how we position our patient. There's a risk for infection because we're fixing to enter the body, right? And there's also a potential for hypoventilation of the patient. Okay, we're fixing to sedate them, put them out, so that there's a risk that they're not breathing well enough to support their bodily needs, right? So that's up to us to monitor for that. But that's our three main things, okay? Again, it's safety, all right? Infection and injury, and then also the risk for hypoventilation. So your book goes into how to take care of some of this stuff and prevent some of this stuff, okay? So in order to prevent injury, the first injury related to positioning, you can have injury related to all sorts of things back there. But injury related to positioning, we got to make sure that we've got our patient positioned appropriately for the surgery that they're going to have, okay? I guess I could change the slide so you can see it. Sorry. Positioning is important, that we getting good, correct skeletal alignment. We've got to remember this patient is going to be basically dead weight. No control of skeletal muscle. It's up to us to control that, okay? So we've got to prevent any kind of undue pressure on their nerves, skin, and then their eyes. We close their eyes. So we can't be pressing down on their eyes. We've got to position them in a way that they get good thoracic expansion. We can't be blocking off blood flow. We do want to make sure that we keep the patient covered as much as possible. Okay. Not only for modesty issues, but also just trying to keep them warm. Okay. And we've got to make sure that we recognize and respect their individual needs. Okay. Previous problems. If somebody's got a really bad back, okay, and we've got to put this person in the lithotomy position with their legs hanging up, we need to account for that bad back. Okay. Maybe there's a different kind of position that we can use for that type of surgery. You think about doing surgery on a patient who has contractures. What's contractures? When they're drawn up, right. Their legs are drawn up, you know. Wow. So positioning, we've got to be able to allow to get to the surgical site. We've got to be able to have the administration of anesthetics. And we've got to be able to maintain the airway. Your book has this picture in it of the majority of your positions. There's always some weird ones, but this is the majority of what you're going to see there. Certainly supine, lateral, and lithotomy are your biggies, all right, your main ones. But the positioning of the patient depends on what surgical procedure that they're going to have. It depends on the physician preference sometimes. The age, the size, the weight of your patient. And then again, some of the limitations of your patient. Not always, no. She said, do they always position after anesthesia? Not always. If you've got somebody who's got a bad, who has limitations, sometimes they'll go ahead and try to get the patient positioned and comfortable before they do. And then sometimes if you've got a really large patient, you want that patient to help you move. Yeah. So we always want to make sure that we are positioning our patients slowly, okay, especially the very elderly who have these arthritic joints and bones and everything, plus the fact that if you've got a patient who's getting general anesthesia, they tend to have hypotension when you move them rapidly. Okay, so you don't want to throw them into hypotension. So moving them slowly. Patients that are in the lithotomy position, we take their legs down at the same time. Okay, controlling the legs. Got to make sure that you've got good padding under your patient. Use whatever you can to get those bony prominences padded. Your patient may be laying there in that position for 3, 4, 5 hours and longer. So good padding, continuous assessment of your patient's circulation. Looking at their color. Okay. Anesthesia is going to be monitoring their vital signs and that kind of business, but they also may be looking at mucous membranes, checking capillary refill. The circulator may do that. The anesthesia may say, hey, check the cap refill for me. Okay. And then once your patient is on the bed, the OR bed, they do use straps to keep them on the bed. So we got to make sure that we're not occluding blood flow or, sensation and all that business because we got the straps on too tight. So we monitor that. Just think about it. Your patient is completely unable to communicate with you. You think about being put in that position right there, much less that one, or that one. But even that one, and you're turned over on your belly, and you can't move, and you can't communicate. Okay. Maybe your ears turned funky when they turned you over that side. You got to think about things like that. Okay. In your book on page 281 is prevention of complications from positioning, chart 17.4. Look at that, please. You may see that information again. So what happens if we don't put our patients in good positioning for their surgical procedure? Look at all this business. Oh, bad news. Muscle strain, joint damage. You can actually pop joints out of place. Okay. Of course, pressure ulcers. You can damage their nerves. And then, like I said, general anesthesia causes peripheral vascular dilation and some pooling. Okay. So position changes affect where pooling occurs. So when you start moving around and jostling them around, you got to watch their blood pressure. And you'll have patients post-op that'll tell you that they're sore in, places that don't have anything to do with the surgery, and it has to do with positioning, especially if they're elderly, very arthritic. Okay. Those big people, we just don't bend and flex like we used to. So, okay. All right. Questions about positioning. Big deal in the OR. Now, in order to prevent infection, remember that's your other risk, one of your other risks back there. We've got to make sure that we use a good skin prep on the patient. Got to know what your patient's allergies are before we go in there and put a whole bunch of betadine, iodine solution on them. Okay, got to find out that. Did they do any kind of skin prep prior to admission? Did we have them bathe in the antiseptic soap, take a shower and that stuff? Sometimes we do, just like we talked about last time. So skin prep usually will start before the patient even gets to the OR. What did we say about hair removal last week? Do we shave? We don't shave. What do? We use clippers, okay, to remove the hair, not shaving. And then once the patient is in the OR, we'll do a scrub on the site. Your book also has a picture of that too. It's and I'm sorry, I think it's it's in the previous chapter. It's in the pre-op chapter. But somebody who's having an abdominal surgery, they prep them from here down to their knees almost. Okay, it's not just this kind of thing like you do when you're doing a dressing change. Okay, it's from here to here. Okay, or if it's a hand surgery, it's from here to here. It's long, it's big areas that we scrub because we do want to make that as aseptic as possible. Okay? And then during surgery, we always are concerned with aseptic technique. Okay. Who is more at risk to get an infection from a surgical procedure? What types of people? The elderly, immunosuppressed people, diabetics, obese people, anemics, right. Anemics. Is that I don't think that's the word. Yeah, anemics. But I know what you mean, Margaret. So that's one of those risks and one of those things that we've identified already. And while we're going to be really diligent in our aseptic technique back there, we just need to know that post-op, we need to be aware that this patient may develop an infection. Okay. So those folks are at risk. Folks with kidney disease, liver disease, those folks that maybe can't process the antibiotics and things that we're going to give them. Okay. Your physician may use an antibiotic solution to irrigate the wound before they close. Sometimes that's done, especially with your abdominal surgeries, okay? With your bowel surgeries, they may do that. Wound closure is very important. Your patient may have sutures put in. They may have staples, or they may have a combination. or they may have surgical tape holding the wound together. That's just surgeon preference and based on the patient, okay, what they had done. Page 282 shows you some different types of things that may be put in for your patient. And your book also talks about when the physician uses sutures, there's all different kinds of sutures out there, guys. There's kind that are absorbable, which means after a period of time, the body breaks them down and they just kind of dissolve on their own. And then there are some sutures that are non-absorbable, which means we have to go back in and take those out if they're at skin level. Okay, we'll take those out based on what the physician says. Okay. Your patient may have retention sutures put in. If you have a person who is at risk for dehiscence, or if it's just a really a bad infected type wound, which also puts it at risk for dehiscence, your physician or surgeon may put in what we call retention sutures, just to kind of help hold that incision closed. Normal sutures, it's a risk for them opening up with normal sutures, so they use those big old sutures, retention sutures. So once those are put in, we've got to make sure that the wound is sterile. The physician may inject antibiotics around the site, the surgical site. They will clean the surgical site and then they'll dress it. So your patient will come out of OR with the dressing. Again, it's just making sure that that wound is sterile when that patient leaves that OR. So, may have antibiotics in the wound, around the wound. The wound will be cleaned with antibiotic solution, and then the dressing will be applied. The type of dressing applied depends on the surgery as well. If you've got a big risk of bleeding, then they may put on a pressure dressing. Okay, have you seen those? Have they talked about those? Did they in 102? Okay, that's just a dressing that is put on, and the tape or bandage is stretched very tight across the incision to hold pressure on the wound to prevent bleeding. You're going to see pressure dressings if you have a liver biopsy, if you have a kidney biopsy, any kind of dressing that there's a risk for, any kind of procedure, that there's a risk for bleeding. Okay. If you have a patient that you're removing an arterial line, okay, you want to put a pressure dressing on that. You're going to hold pressure for a good while, but then you want to put a pressure dressing also. Okay? Right. Yes, ma'am. Because of that, yeah. And you can't. You can't observe you can't observe the incision post-op, so we have to look at the dressing, and see how much, if they're having any drainage and that kind of thing. And we don't leave dressings on for, a week anymore like we used to. We open them up and let the air get to them. But, yeah, for that immediate post-op period, and usually the first 24 to 48 hours, they're dressed. So you just have to assess the dressing, right. Okay, all right. Your patient may have drains put in as well under your dressing to help pull out fluid, pus, drainage, whatever, so that we don't get collection of those fluids in there, and then you've got a big hematoma and a big mess up under there. Okay, so a drain may be put in, and we'll talk about those a little later. Okay. The other issue is hypoventilation. Right? So how are we going to prevent hypoventilation in our patient in OR? We can intubate them. We give them oxygen. And what else? How do we know? looking at their O2 sat, monitoring their vital signs, monitoring ABGs, all that business, right? Okay. One of the patients in OR, they usually will document their anesthesia will usually document vital signs every 5 minutes, and then right after the surgery, we have a series every 15. Then there's a process there, but strict diligence in looking at what are their values, and that's why we need to know what the baseline is. Maybe 92 is their baseline. All right. Okay. This is a picture of a timeout sheet or an identification of potential risks, surgical site issues. I think this is in your book. Everybody's forms are different. So this is just an example. Okay. But if you look, oh, nope, get back up there. If you look at this one, they do, this is the pre-op and all that business stuff, making sure that the unit that's sending them has done all this business. That's part of their checklist. Okay. The holding area, looked at it again. Okay. Somebody marked the site. Any comments? Then they do this place does an anesthesia timeout, confirming everything prior to the start of anesthesia. And then the surgical team does a timeout. Okay, prior to the start of the procedure. This is when they're in the room. Okay. And then this is looking at some safety fire. You've always got a risk of fire in the OR. Okay, so timeouts they have to be done. How many that your facility chooses to do, I don't think there's a set number, but before that cut is made, the group's got to back up and say, this is it. This is what we're doing. So everybody's on the same page. So I don't know what was said last semester, but that's what I'm saying this semester. Okay. All right. Okay? Questions about that? It's a safety issue. Safety issue. All right. You've got to make sure that you know about, the majority of the folks that we see in the hospital, they're elderly, right? Those are the people who get sick. So patients who are going to surgery that are elderly, they've got all these extra issues going on simply because they're elderly. So you need to keep these things in mind, okay? Anything that we do, any medications that we give our elderly folks have got to be very carefully titrated. What does that mean? It has to be adjusted based on the patient's response. Miss Lee's making sure I'm right. Did you name me? I am. I'm gonna finish the slide and then I am. Yes, because they're fixing to start packing up if I don't. Okay, so you've got to make sure that you're adjusting based on your patient response. All right. You can't throw your patient into an arrest, okay, because that's what we normally give all of our patients, okay? Got to be titrated. Be aware that those physiologic changes that occur in patients will alter their response as well to the medicines that we give them, to anesthesia. They do not replenish fluids and volume very quickly. So we have to be very careful about blood loss, fluid loss in the elderly patient. They become hypothermic quickly. And those of you who have been back in the OR, they might as well roll you into a freezer, right? They have altered responses to pain. They just don't tolerate the surgery, positioning, the anesthesia as well as they used to, or as your younger patients. Okay? And then they may just not be able to communicate their issues or follow directions. And we talked about, some of those sensory issues. Maybe they don't hear you. Maybe they can't see you well, okay? But we have to adjust accordingly. And then, of course, they've always got problems with their skin. Always, always, always. All right. So if I give you a situation and I say, I'm expecting you to take into consideration the age of the patient when you're making some of your decisions, right? Because you're going to be doing that when you're out there taking care of patients. I hope. Okay. Break. Okay, let's take a break. It's going to be something you're going to have to deal with in some form or fashion. If you're working anywhere that they do testing, procedures, those kind of things, because we'll talk about different kinds of anesthesia, and they use anesthesia at the bedside in the patient's room sometimes, and you guys will be helping with that, okay? But anesthesia is defined as an induced state of partial or total loss of sensation. Partial or total loss of sensation. And this may be with or without loss of consciousness. So when we're talking about types of anesthesia, these are your three main: general, regional, or local. And then you have moderate sedation, which we used to call conscious sedation. You may also hear it called MAC, monitored anesthesia, whatever the C stands for. Good Lord, it went right. Monitored anesthesia care, we'll say, but it's that just went right out of my head, and it'll hit me tonight about 12:30. I'll wake up. I'll send you an email. Monitored anesthesia care. Maybe it is care. Anyway, but it's along the lines of moderate sedation, okay, and we'll talk about that. But the type of anesthesia that your patient is going to be getting is really based on a discussion between the patient and the anesthesiologist or the anesthetist. Okay. It's really based on the type of surgery that your patient is going to have. It's based on the patient's health status. We can't put everybody to sleep. Not everybody is a candidate for general anesthesia, and we'll talk about that. It depends on the last time that your patient had anything to eat or drink. Another factor that plays in is their previous response to anesthesia. It may be a safety issue that causes us to choose one over the other. And then we also have to look at, is this an emergency situation? Which one of those types of anesthesia do you think carries the biggest risk? General. We're putting the patient completely out, right? So if your patient just got pulled in from Casablanca because they suddenly, have a ruptured appendix, we're going to have to think about some things like that. Maybe that patient can't be put to sleep right at the moment. You got to consider those types of things. All right. And we'll talk about some of that. Remember some of those medicines that we talked about that causes the stomach to be empty quicker? A lot of things play into it. So you're looking at when they last ate or drank. Maybe they had a huge issue the last time they were put to sleep. Okay. If that's the case, then we're going to have to alter the way that we put them to sleep, or we're going to have to choose another kind of anesthesia. So all that stuff plays into account of what is chosen. So when we're talking about general anesthesia, this is when we're actually putting our patient out. They are out, okay? It acts on the central nervous system. Your book talks about stages of anesthesia. One, 2, 3, and 4 are the stages. I'm not so concerned that you're able to tell me everything about those stages. Stage 3 is what we're going for. Stage 3 is what we're going for, especially when we're talking about general anesthesia. This is when the patient has lost their, they can no longer hear, they have lost all consciousness, and they have no response to pain. Okay? When your patient progresses to stage 4, that's past what we want them to be. We got to do some recovery and some resuscitation at that point, okay? But when we're talking about general anesthesia, it causes a loss of all these things here. Your patient loses consciousness, sensation. Don't look at the spelling on control. But they do lose their reflexes and control of skeletal muscle. They even lose their ability to blink when you touch their eye. That's how out they are. Okay? They have no pain perception, and they have no memory. Okay? General anesthesia can be administered through different routes. Certainly your IV and inhalation are your two biggies, and we'll talk about that. But with general anesthesia, we usually have to use reversal agents in order to stop the anesthesia process. Okay? Now, it'll wear off, but it takes a while. Okay? So we use reversal agents to start bringing your patient out from general anesthesia. Table 17.3 in your book gives you some of your more common general anesthetics. But when we're talking about IV induction agents, remember when we were talking about pre-op, we talked about some sedatives and anti-anxiety medications, things like that we may give the patient pre-op that would help to induce anesthesia. It would help to, kind of chill the patient out. It helps anesthesia work better. Okay? They may get another dose of these medications, and here's some examples of them, once they get back there and they get ready to start the procedure. Okay? IV induction agents like Versed, fentanyl, Diprovan, those are usually given as a single dose. It only lasts a few minutes. Okay? And it causes the patient to quickly go into a pleasant sleep, and it happens quickly. That's when you start to count backwards from 100. Okay? And you get to about 98, and that's it. Okay? But pretty much all of your general anesthesia cases will get some kind of IV induction first. So they do that, it puts the patient out, and they use this time to intubate the patient. Actually put a tube into the trachea so that they can control the airway. So we give them their IV induction agent, then we've got them intubated. Now we're going to use the gases, the inhalation agents. This is your Penthrane and furane, and they're all pretty much end up with AIN. Okay, nitrous oxide, except for that one. Okay, but these are agents that we use and are administered through vaporizers. They're mixed with oxygen, and then it's in a gas form. They're given to your patient. Your patient usually will have a mask on first, or they may be intubated. That's what ETT is. That's an endotracheal tube. ETT. A laryngeal mask airway. This is another type of airway that's used that covers the larynx. Okay. Or they may have a tracheostomy, which is a hole in their throat that you can administer the gas through. That's their airway. Right. So basically, the gas is breathed in and it enters the body through the alveoli. It's absorbed that way. Sometimes they'll give you the IV induction. They'll put a mask over your face and say, take a couple of really deep breaths, and then they'll intubate. Depends on the practitioner. It does. So when we're talking about some of these medications and general anesthetic, it's usually the inhalation agents are very easily administered. It's just breathe. Can I go back one? Sure. Go back two? Are these on Blackboard? No. The notes that you have are what you have. I want you writing. That's why I don't put it all out there for you. Sorry, I'm a mean old girl. That's fine. Do I need to go back one more, guys? One more? Hmm. Yes, that's some big stuff right there, yeah. Okay, so when we're looking at the pros for the inhalation agents, like I said, they're easily administered, very rapid excretion by ventilation. One of the things is when you get ready to stop the inhalation agents, you stop them and turn on the 100% O2. Do you remember when they woke you up from surgery? What were they telling you to do? Breathe. Take some good deep breaths. And they kept telling you that over and over again, right? That's so that you're trying to blow off some of those inhalation agents there, okay? Now, the cons for some of them, they can be kind of irritating to the respiratory tract. You know, any time that we're giving medications to the respiratory tract, you can have these complications. Okay? We're irritating the inner lining of the respiratory tract. So you're going to cough. You can have laryngospasms, bronchospasms. It can cause the secretions to be, increase in amount. They may be thicker. And of course, one of the complications is it just makes us not want to breathe. It may depress the respiratory drive. So you think about that. That makes sense, right? If I'm shoving drugs down in there, it's going to irritate something, right? And when I start irritating the tract, I'm going to cough. I can have bronchospasms, laryngospasms. It's going to affect the secretions. You know what? When you have the respiratory lecture, module, whatever it is this time, I bet you're going to hear that again. Okay. It's not just a medication issue. So when we're talking about intubating your patient, endotracheal intubation, there is a picture of what an ET tube looks like on page 674 in your book. But this is the primary way that we give those inhalation agents, is we go ahead and intubate the patient because we have good control of the airway. Okay, this is done by your anesthesia people. In the OR setting it is. But the tube is actually inserted into the trachea. There's a bulb on the end of it that we blow up, like a Foley bulb, right? And it blocks off the trachea so that if the patient does vomit, they don't aspirate. And let me tell you right now, if I'm one of the people that y'all are having to do this for, I'm going to need some serious medication ahead of time. I've told all my EMS people at my hospital, make sure I am near dead before you do this to me. I'm not going to be a good girl. Okay. So it can be very traumatic, but again, you got to do it. It does carry complications. We're putting a big old tube down into the trachea. So what you have is you can have trauma to the upper respiratory tract, trauma to the trachea. It can irritate those tissues. Okay. This is why your patients complain of a sore throat after surgery, after general anesthesia. It's usually not the anesthetic agent, it's because of the tube. Okay. And some of your complications with intubation has to really do with the agents that we're giving them, not so much the intubation itself. Okay. But your patients with general anesthesia will be intubated. And if they're not intubated with this, they may use another form, depends on what is going on in this area. Okay, there are other types of airways that they may use, but they've got to get good control of that airway. Okay. All right. Complications from just having general anesthesia. They can be anything from minor, sore throat, to major, they die. Okay, that's the whole spectrum there. Okay. Most of the time, thank goodness, patients do well. They just come out with a little sore throat. But there are some major things that can happen. Your book talks about a condition called malignant hyperthermia. This is a condition where your patient has a reaction to certain anesthetic agents that we're giving them. Okay. It tends to be a hereditary thing. This is why we ask, has anybody in your family ever had problems with anesthesia? Okay. It is rare, but it is life-threatening. What happens is this reaction causes your patient to have a very increased metabolic rate. The body temperature, as a result, starts to increase, and the temperature can go up to 111. Okay. Everything speeds up. And it has to do with the calcium in the body. Y'all will talk about calcium when you get the fluid and electrolytes. But just know this is what's happening. Everything is speeding up. All right. They get tachycardic. They have hypotension. The blood pressure drops. They become cyanotic. And they get muscle rigidity, especially in the upper chest and the jaw. Okay, and it has to do with those electrolytes, calcium, potassium, and the ways those things are affected. Okay. So, the first signs that you usually see in a patient who is getting into malignant hypothermia, and it's usually very quickly, is they have changes in their oxygenation status. Their CO2 goes up and their oxygen level goes down. Just a drop. Okay? That's an early sign. The tachycardia, their heart rate speeds up pretty quickly. That's an early sign. When their temp gets really, really elevated, that's a late sign, and I hope it has been identified before then, because this is something you've got to intervene quickly. In your book on page 273 is a pretty good-sized chart on what we do for malignant hyperthermia, but our basic goals are to get the temperature down, to treat the acidosis that they have with everything speeding up, okay, and maintain their oxygenation. Temp, acidosis, and maintain their oxygen status. All right. So basically, we stop everything that we're doing, stop all their anesthesia agents. If the patient is not intubated, we will intubate them at this time and ventilate them, 100% oxygen. And then the medication treatment for this is Dantrium. We give it as an IV medication. If we can, we will stop the surgery and get the patient stabilized. But that may not be an option. It depends on where you are in the surgery. Okay. So look at that chart. I thought it was very interesting that they actually have a malignant hypothermia national foundation or whatever. I guess you can have a foundation for anything, but that's, pretty neat. Anybody know of anybody who has this problem? It's not common. It's rare, but people die if you don't intervene and get it taken care of. Yes, sir. It depends on how sensitive they are to the medication, but sometimes it happens within just a few minutes of administration. Sometimes you're on into the surgery. Because they may give a combination of medications for their anesthesia. That's why screening is just really, really important. Because you can avoid, if you know that your person had, or their family member had an issue with fluorine, okay, and they had some problems with their temp and all, you're not going to give that patient fluorine. You're going to go to another medication. Okay. Other complications that you may run into with general anesthesia is that we may overdose them on the medication. Okay, this is going to be more common in your elderly people. Remember, they can't handle meds like they used to. Your older people, your folks that have kidney and liver disease, they can't metabolize those drugs correctly, so they don't excrete those drugs. They stay in the system, so they can get into an overdose. People with metabolic issues are at risk for this. These are those folks that progress to stage 4 of anesthesia. Okay, that we have to do some resuscitation and some reversal and those kind of things quickly. We may have hypoventilation that is unrecognized. And then there can always be intubation problems. Trauma. Maybe the first thing that you do when you get that tube in, when you get a patient intubated, is you check the placement of it. Okay, we're not ventilating the stomach, we're ventilating the lungs. So you remember how when you put in an NG tube, what was the first thing you did when you got it down? You check the placement, because then you wanted to be feeding the stomach, not the lungs, right? Same concept. Okay, both those tubes are laying right there together. You got to make sure you're in the right one. So you can always intubate the wrong place. How do you think you know that? How do you think you know that you're in the wrong place when you have intubated a patient? You may see some secretions in it. The tube doesn't go all the way down. The tube's only going to sit right here. You hear no breath sounds. What else? The chest doesn't rise and fall, but what does get bigger? The stomach. The stomach blows up like a balloon. Yeah. So to check placement, you listen to breath sounds both sides, all 4 lungs, right? If you may hear it on the right side more than you hear it on the left side, that means that you've put the tube in and you've gone down the right main stem bronchus. So they may ask you to pull the tube back a little bit. Okay. A little more than you want to know at this point, but anyway, I think it's interesting. Okay, so again, you can always have problems with the intubation. Sometimes the intubation is just a very difficult placement. It may not look like everybody else is in there. You think of somebody who's had a radical surgery, the neck muscles or something like that, okay? It can always look different. So that'll be an issue as well. Questions about general anesthesia? Okay? All right. When other types is local anesthesia. This is either your topical, which is usually a cream or an ointment or something like that they put on the skin that deadens the skin. It's absorbed in, then we'll deaden that area. Anybody know an example of a topical? Lidocaine. That's an infiltration. They inject that, but they do have lidocaine gels and stuff like that. You're right. Another thing is that EMLA cream. Have you heard of that? That they put on where they may start IVs. Put that on. They put an opsite over it or a transparent dressing over it. Wait an hour so that it's absorbed into the skin, and then they go in and try to start the IV. Okay, they use that some on kids. Okay, if you have an hour for it to work. Almost out now. Okay. So local anesthesia is not a lot of. What do you think some of the cons are with local anesthesias? They're quick. You're not quite that tore up, right? You're not quite as anxious about it. It's all right. I'll go with either one. That's all right. You're thinking pros, cons. That's all right. You're thinking. There could be a risk for infection, but there's a bigger risk of irritation and allergy. Yes. But if you can get by with that, certainly you don't have the systemic responses and issues like you do with the general anesthesia. Okay. All right. Regional anesthesia. That's your local anesthesia where you put it at the site. Did I not talk about that? I'm sorry. Sorry. Ooh, y'all are paying attention. What can you think of that you would be an infiltration? Lidocaine at the dentist, where they just deaden that area. Right. To get stitches? Absolutely. Absolutely. I've lost some slides. No, I hadn't. There it is. Okay. So again, the people who you don't have the systemic responses even when it's a local injection or an infiltration. Okay. Local xylocaine and local lidocaine is not going to affect the heart. Now, if you go crazy with it, it will, but just as a local infiltration, it's not going to do that. Topical is on the outside of the skin. Infiltration, we have put it into the body and it's spreading out in that area. We have infiltrated the tissues. Okay. All right, regional. These are some examples of a regional. This is where we're going to anesthetize a certain region of the body, a little bigger area than an infiltration. Okay? We're really blocking peripheral nerve conduction. When you have a field anesthesia, you're blocking the field, all right, around the surgical area. Nerve blocks is where you're actually injecting the nerve or around the nerve that supplies the area that you're going to be doing the procedure on. If you're going to have, when I had arm surgery on my hand, they deadened this nerve up here to deaden my whole arm. Okay. Carpal tunnel. Too much of this. I had gotten where I couldn't hold an IV catheter. I've had it on both of them, yeah. But it was nothing. If you have to have that done, it's nothing. Versed, it's a wonder drug. Good stuff. Then you get into your epidurals and your spinals. These are where they are actually injecting medication into your back. Right? Spinal is where we're putting it into the cerebrospinal fluid. And then the epidural is we're putting the medication in the epidural space. Okay? Not the best picture right there. Sorry, guys, but there's some pictures in your book. So the nurse's role during this spinal and regional type anesthesia administration is basically to help get the tray set up, right? Have everything ready. It's for patient support, and then to help the patient with positioning. Patients who are having, especially the spinals and the epidurals, they have to be positioned with their back bowed out. Who's had a baby recently? Y'all suck them hands right back down. No! Who's had an epidural? What? Good Lord, it's prevalent out there. How did they put that in? You're sitting on the side of the bed with your feet dangling off, and you're leaning over like this with your back hunched out, pulling those vertebrae apart so that they can put the needle in there. Yes, ma'am. because what you're wanting to do is you're wanting to deaden both sides. So it depends on where the tip of your needle is. Yeah. Yeah. They because you're wanting that's your goal is to get them both. Get both sides, please. So you have to make sure that the needle is positioned just right, and you can actually go on into the spinal and get past the epidural space. So you're looking at, no, they may not have been in the epidural space at all. Period. You didn't, but you sure wanted to. You sure wanted to. Miss Taylor. What? Uh-huh. And they voted out that way? Okay. I was trying to get a picture of that. You said, and they were under me, and I'm like, that wasn't coming to my head, but I got you. That would be a little difficult, but okay, I'm with you. But again, you got to go with what's going to work for the patient. What is going on with the patient. Okay? Not everybody who is needing a spinal or an epidural is able to sit on the side of the bed and bow their back out. They may have to lay this way or prone. Yes, ma'am. Sometimes it does. You're moving it around. You're moving it around in that epidural space. Yeah, that doesn't mean it's wrong, but yeah, moving it around. Yeah. Okay. So your goal here, and you're kind of helping that patient to maintain that position. Okay. And then of course you're monitoring your patient afterwards. Okay, but still, the anesthesia part of that is anesthesia's role. Okay, so the advantages to a regional anesthesia is it actually allows the procedure to occur, but you don't have loss of consciousness, and your patient is not sedated. There's a rapid recovery. However, the duration will last a little longer over into the post-op phase. Okay, but once it starts to wear off, it's a pretty quick recovery. And it's a very good alternative to general anesthesia. I have seen them do surgery using a spinal on patients that the only reason they did that is because the patient was so terrified of being put to sleep. No medical reason other than just severe anxiety about being put to sleep. And you can use regional spinals, those types, in emergency surgeries if you cannot put the patient to sleep for some reason. Well, the patient doesn't need to be intubated with regional. They don't lose consciousness now. I'm going to need some Versed, but with Versed and those kind of things, the patient is still maintaining their airway. Yeah, now if you're having a laparoscopic, because they blow you up like a big balloon with laparoscopic. Yeah. So. For brain surgery? Yeah, because you need to respond to them. Not if they're in the gut. No, they put you out, or you're deadened for that. No, exploratory, they're going to put you to sleep for that. But no, the patient is usually given some type of IV sedation just to kind of relax them a little bit, and then they do the regional, the spinal or whatever. But the patient still maintains their airway. Okay. Disadvantages. Of course, the patient can always have an allergic response to anything that we do to them, or any medications that we're giving them. Maybe it's just technically difficult to get that catheter into the back. Okay. Painful. Sometimes the anesthesia does not stay where you want it to. It can migrate up in the spinal column, and then you've got more anesthesia than you want. Okay? Systemic absorption. When you start to have systemic absorption, that means it's out of the spinal column. You start to see CNS problems systemically. Okay, the patient may be very stimulated at first, and then there's a certain decrease in their level of consciousness, their respiratory effort, those type of things. Okay. Cardiac depression. More things get depressed than you want depressed there. You can have toxic effects just from an overdose in the medication. Local tissue damage. And then one of the things that you may see, especially with a spinal, is a post-spinal headache. When you first put when they put the needle into the patient's back, that one of the ways that they know that they're there is they start to leak cerebrospinal fluid. Okay, and so throughout the procedure, they may lose cerebrospinal fluid to where they have a headache. A bad headache, and it's just from the pressures and all, from the loss of that cerebrospinal fluid. So what they do is they go back in and they take and put what we call a blood patch in, and it's really just a little amount of the patient's blood they inject back into that spinal column, okay, that equals out those pressures there. Okay, so if you hear of somebody having a blood patch, it's not like a patch they put over it. It's an injection of blood, the patient's blood, that they put in there to equal out that and to take care of those spinal headaches. What do you have to, when you have a spinal anesthesia, a lot of times, well, most of the time, your patient has to lay flat for several hours. That's one of the drawbacks with that, because you're wanting to not lose a lot more of the cerebrospinal fluid, because if you set them up right after a spinal, they do get that headache. And it's a really bad headache. It hangs with them. Okay, so that's when we have patients with spinal anesthesia have to lay flat post-procedure. And it depends on your organization for how long, but it's usually like 6 to 8 hours. Good nursing assessment throughout the entire time that your patient is getting these regional anesthetics. You've got to watch for changes in their CNS function. Okay. Are they very restless? Is their speech slurred, incoherent? Are they having problems with their vision? Nausea and vomiting? Some of your patients may complain of having a metallic taste in their mouth. They may have tremors, seizures, So what are you noticing? They're neuro symptoms, right? You're in their spine. So you're going to see neuro symptoms when things go wrong or when you have complications. Right. Your patient may have some changes to their vital signs. If they're starting to get restless, those kind of things, what do you think happens to their vital signs? Goes up. Blood pressure goes up. Temp goes up. Blood pressure, pulse, and respirations all go up. So we're watching the airway. We're watching the O2. We're watching their CNS function. And if we start to have issues with that, we've got to make sure the surgeon and anesthesia knows about it. Okay. And then they may be given some type of barbiturate to kind of settle that back down. Okay. But you have to recognize when that stuff's going wrong. The patient can die from it. All right. If it's not taken care of, the blood pressure will eventually drop. Yeah. Sometimes just by putting in the epidural or the spinal, the blood pressure will drop initially. That's just from the procedure. Okay, that's why you may have noticed they probably opened up the IV fluids to hydrate them very well. And sometimes in OB, they'll just open up the fluids because they know that they're coming to do the epidural and make sure they're good and hydrated. And that helps with headache as well. But that's bile and gastric juices, yeah. Yeah. Was she pregnant in OB? Oh, yeah. Mm-hmm. Just trying to move the baby around where they can find the heartbeat. Yeah. Mm-hmm. All right. Moderate sedation is the other one. With moderate sedation, guys, you're using IV medications to decrease your patient's pain or awareness, and they do not lose their reflexes. This is the stuff you do that you may do at bedside. But they also do this. They can do this anywhere. But moderate sedation is used for diagnostic and therapeutic procedures like your endoscopies, your cardiac caths. If you're doing any kind of procedure that's kind of short and you don't want to put the patient completely under. Okay. Cardioversion, where you're shocking the heart. Okay. They'll give them moderate sedation for that. But the administrator of this is going to be an RN. It's usually an RN with specialized training to administer those drugs and to do the follow-up monitoring on your patient. And sometimes that's just knowing, being ACLS certified, advanced cardiac life support. The nurse has to know how to administer the drugs, and it's usually just an IV push, but then they've also got to know how to monitor vital signs, O2 sat, the heart monitor. You're also monitoring their airway and their level of consciousness during the procedure. With moderate sedation, these are medications that work pretty quickly, and you have a rapid return to baseline. This is your Versed, Valium, Diprovan, those three. And see, we already use those again for IV induction, right? You're just not going the extra step to get general anesthesia. You're just giving them small amounts of the medication, and then for the next every 15 minutes or so, it depends on your organization's policy, but you will have a monitoring policy for patients who are getting moderate sedation. Every 5 minutes you document this, or every 15 minutes you document what their values are. But once the procedure is over, then the nurse is responsible for monitoring those things post-op as well, and documenting that. Okay, so the patient, we're monitoring vital signs, level of consciousness, O2 sat, vital signs, EKG. We don't want any weird rhythms going on in there. So your patient's going to be sleepy during moderate sedation, but you can arouse them, okay? You can, just by calling their name, they're arousable, and they can follow directions. Or they should be able to. Patients react differently, but most of the time, your patient should be able to cooperate with you and that kind of thing. Yes. Your patient may be awake, but they may not remember. Yeah. Sometimes they do, sometimes they don't. Some people will just wake right up, and other people, My mother and Daddy both had a colonoscopy on the same day. Can you imagine? I just said put them in the same room. Just put them in the same room. My dad comes back. He's sitting up on the stretcher, Indian style, wanting to know, when can I have my coffee? Okay? My mother, for 3 hours. Okay, she didn't know anything for 3 hours. The Versed hit her hard. It didn't hit. He was fine. So she didn't remember anything for half the day, really. So it's just the difference, So, yeah, that was a fun day. No, what was fun was the 2 days ahead of time with the prep. That's what was fun. Because my mother's doing what she's supposed to do, and my dad's just grabbing. I don't see why you have to do all this business. So, anyway. Okay, so, it's 2 for 1. Do them on the same day if you can. All right, so when we're talking about intraoperative phase, all right, think about nursing diagnoses. We've already talked about what our focus is on, okay? So give me some nursing diagnoses for the intraoperative phase. Risk of infection, absolutely. Risk for ineffective airway clearance or ineffective gas exchange, however you want to say it. Right, good. You're thinking respiratory. Great. What else? Risk for falls, risk for injury because of, positioning, falls. Right. What else? Risk of death. That's kind of all encompassing, isn't it? Absolutely. Risk of death. That's number 1 on my list, okay? I want that at the top of my care plan. Absolutely. Risk of death related to what? Everything. Absolutely. All those hazards that are there. True. What else? Risk of hemorrhage. Risk of blood loss. Sure. Risk of aspiration. Gosh, y'all are thinking all of it. What else? Risk to skin integrity, right? Risk for allergies. Wow. So do you see everything pretty much, right? So you got a risk to their cardiac status, a risk to their respiratory status, risk to their skin, okay, a risk to their safety. How about a risk to their body temperature? It's cold back there. Okay. Is it cold in here to you? They have a risk. They have anxiety issues, of course, but we cure that quickly, right? Okay. So good. So think about your patient that's going to surgery. We've identified hopefully some problems or some risks pre-op based on the patient, but then when they get to the OR, they have this extra set of issues that's piled onto them. Okay? Great. Good. All right. Any questions about intraoperative? All right.